So tonight, to start out our discussion, to let you know kind of where we're headed, we're going to start out talking about anatomy and kind of it's very important to understand the normal anatomy and kind of where all the parts are. So that's really important. We're then going to talk about the different causes for pain. Then we're going to talk about really why should you see a healthcare professional? And then what are the treatment options? It's very important to understand that there are so many options for care here. And it's really, really important. I had a patient come in to see me once that had said her provider told her that this was probably all in her head. And I want to let you know that pelvic pain is not in your head. There is definitely something else going on. And what's a wonderful thing is we often can make it much better, if not completely resolved. So the first question is like, why do I have pain? What's going on? And we need to understand this pain can be there all the time. You can be aware of, and I'm sorry, I'm gonna apologize in advance. I do talk about vaginas all day long, so my terminology is I just kind of put it out there. So I'm gonna apologize, but is that pain vaginal? Is that pain on the vulva? Is it there all the time? Is that pain only associated with intimacy or with sex? Is it only when you wipe or during other personal care? Does this pain happen when you're passing your urine or moving your bowels? So the idea is we want to look at that pain and address all of those areas of pain. It's very important, and this is what's so exciting about this lecture is that I really believe that treating pelvic pain is a multidisciplinary approach. And what that means is working together with a team of healthcare providers to one, help figure out the cause and then come up with a plan. And so, like at the Center for Incontinence and Pelvic Health, I work with Rachel and her team all of the time. We work with primary care providers. We can work with your gynecologist. We actually work with pain providers. And so to let you know that it's very important that we want to treat you as a whole person. You're not just your pain. So I'm going to leave this over to Rachel because she has lots more experience with muscles than I do. So I'm going to let her do the anatomy of the female and male.
Okay, here we go. I'm just going to change my, okay. So this is a view of the female genitalia. I'm going to start with labeling the bony landmarks. So kind of at your 12 o'clock position is the pubic symphysis. 6 o'clock position is going to be the coccyx. And lateral walls are in between the ischial tuberosities, also referred to as the sit bones. So Kathie alluded to this already, but these external structures are technically the vulva. So the vagina is actually internal, even though a lot of women will refer to this region as their vagina. When talking to a healthcare provider, it can be very helpful to know these specifics when they're asking about, the area of your symptoms. So just below the pubic symphysis is an area of fatty tissue called the mons pubis. And then as we kind of come down further, we'll get to the clitoris and the clitoral hood, or also referred to as the frenulum. The clitoris here, it looks very small, but it is actually quite a large structure. It extends following the labia majora here on the outside of the vulva, and follows some of the superficial pelvic floor muscles that I'll get into a little bit later. The labia majora it is skin folds that have hair and fatty tissue inside. So they're there for protection and coverage. Just inside of the labia majora, you have the labia minora skin folds. They do not have hair. They have more mucosal consistency and do not contain fatty tissue. And then within the labia minora, we're going to be more specific, is called the vestibule. So you can actually have pelvic pain conditions specifically to this region. Within the vestibule, you have the urethral opening, and then you have these two kind of dots on either side are the periurethral, also known as the Skene's glands. So they secrete lubrication and are thought to have antimicrobial properties. So kind of excreting that antimicrobial properties to help prevent UTIs. Then a little bit lower, there's the mouse, is the vaginal opening, also known as the introitus. And sometimes you'll have remnants of the hymen in this area. And then at the very bottom, we have another pair of glands called the Bartholin glands. They also help with lubrication. Also, what's interesting about this region is we have androgen receptors, referring to hormones like testosterone. So most of this region is very estrogen driven, but here is a unique area that's actually sensitive to testosterone. Yeah, okay. Last thing I wanted to note, kind of going back up towards the top, the clitoris on a cellular level is actually the same as the glands of the penis in males, so the head of the penis. So it's considered erectile tissue. And then lastly, here in the perineum, can't see it because it's under the skin, is a very important structure called the perineal body. So it is a very tight band of ligament that a number of the pelvic floor muscles attach to, in place of a bony attachment, like most muscles attach to. And then just below that is the external anal sphincter, the anus. And that just kind of wraps up the external genitalia. So getting into the pelvic floor muscles, they are part of a bigger system. We like to refer to it as the deep core system. And that includes the diaphragm, the transverse abdominis, and the multifidus, which is a tiny group of muscles along the spine. And so all of these muscles work together to create stability within your trunk and manage pressure. So we have 3 layers of pelvic floor muscles. This view here on the right is of the third layer of pelvic floor muscles. The first layer, chart here. There we go. So these outer pelvic floor muscles are actually what I was referring to earlier that have connections to the clitoris. They extend out and have attachments to the sit bones, the ischial tuberosities, and the pubic symphysis at the top. There are 5 main functions of the pelvic floor muscles. Easy way to remember it are the 5 S's. So support, sphincteric control, sexual, stability, and sump pump. Sump pump referring to the muscular action to help move your blood flow and your lymphatic flow between your top half and your bottom half. And I also like to refer these muscles like a trampoline. So they have the ability to lengthen and contract, and that's one of the ways that they help support the pelvic organs and maintain stability within the pelvic outlet. And last, I got a number of posters here. The third layer of pelvic floor muscles, think of them more like a hammock. So they are predominantly slow twitch muscle fibers. So think of endurance muscles. So they help support those pelvic organs throughout the day, like a hammock. But we also have two hip muscles that extend, they make up part of the pelvic wall that are in the third layer. And that would be your piriformis and your obturator internus. So I love displaying this image in my room because there's so much interplay between the pelvic floor muscles and the larger body, the hips, the back, the core. So we have direct connection to hip positioning and hip strength. All right. So next, can get into a little bit of the male anatomy. They similar but different. So the male pelvis is taller and more narrow. So it tends to look kind of like a heart shape versus a bowl. And then the males have two openings. Females have three. Things that I found interesting with the male anatomy is that they have extensions from the internal and external obliques to the cremaster muscle and the spermatic cord. And those two connections actually help control the scrotum and the testicles and their positioning. So oftentimes I find with my male patients that you can work more globally. So looking at the range of motion through their core, their back, fascial tightness, and can indirectly improve some of their pelvic floor symptoms by looking at the bigger picture. Just like women, their pelvic floor muscles function those 5 S's. And then what else did I want to mention? Oh, you can see in the image here that the prostate gland is underneath the bladder, and it helps support the urethra. So the urethra in females is only about 4 centimeters long, whereas in males, it can be about 16 centimeters. So it's much longer, and the prostate here helps with maintaining support and control. So it is crucial in continence. So when it comes to prostatectomy surgeries, coming in, before surgery or especially after surgery to help strengthen the pelvic floor muscles can be essential in regaining that continence since this organ has been removed. Now here's a quite in-depth overview of the male anatomy based on the layers. They have 3 layers just like females. Organs, difference would be prostate and the seminal vesicles. That helps with ejaculation. One of the differences with the male anatomy is that they actually have fewer muscles than women. So here in the female image, the bulbocavernosus here in males, because there is not a vaginal opening, is one muscle. And then within the second layer, there are 2 urethral sphincter muscles that are in women that are not in males. Okay, that's it for me. So back to you, Kathie.
There you go. All right, so let's talk about your team. And I kind of talked a little bit about this in the beginning. So you can have your medical provider. So it might be your physician, your nurse practitioner, maybe your nurse midwife or a physician assistant. And the idea with that medical provider is that's someone who's going to rule out or identify some medical cause for your pain and to treat that. And when we talk about pelvic floor physical therapists, the idea there is that they're going to evaluate and treat those muscles and structures related to your anatomy so that we can attack this issue from all sides. So let's talk about what happens when you go to visit somebody, because I know a lot of times people put off that appointment because they're very concerned. Oh my gosh, what's going to happen? Are they going to torture me? And the answer to that is absolutely not. It's very important for us to get a very detailed history of what's going on. And so when individuals come in to see me, they do a questionnaire. And when we ask these questions, one, I look at your chart, your medical history, what medications you're on. For women, also pregnancies, what were the deliveries like? What are your family history like in regards to structure and function of those pelvic organs? So we have you fill out a questionnaire, and we talk about your bladder function, we talk about your bowel function, and we talk about your sexual function. How are things? You're going to have an exam because we need to look at the tissue and we need to see what's going on. And sometimes there's even testing to be done. And then the goal again, remember I said in the beginning, we're a detective. We're going to come up with a plan based on what we find out. So as I see, I jump ahead of myself here. So when we talk about history, again, your past medical history, if you've had a spinal surgery, if you've had hip surgery, if you've had a catheter in place, if you're a diabetic, all of those things can make a difference in regards to what's going on with your pelvic health. As I said, we're going to look at medication, urinary, bowel, and vagina health. So, physical exam, when you come in to see us, it may include the majority of these things depending on what you're coming in with. But we always check your urine, make sure there's no infection. We're going to look at that external tissue. And I think I'm going to talk a little bit more about some of that, what we're looking for with that. We're going to examine that inside of the vagina. What's going on there? Is there discharge? Is there irritation? When you come to see me, I always joke around, I get the beginning of the muscles. I identify, can you find your pelvic muscles? Let's get you squeezing. What's going on? Is there relaxation of those muscles? Again, looking at those causes. So we're going to do an exam to look at that and to start you off the very beginning starts of pelvic muscle exercises. Again, we're going to include Rachel and her team because they're going to look at, like she said, your hips, your back, your diaphragmatic breathing. That's not my expertise, but we can get you started. Depending on what's going on and where your pain is, we may do a rectal exam, and we often do swabs to rule out infection, such as a yeast infection, a bacterial infection, sexually transmitted diseases. I'm okay, don't worry, and do that. So we're going to come up with a diagnosis and plan. Okay. All right, let's talk that pain. I had a patient come in today, and it's always interesting to me because I often get pelvic pain as oh, by the way, people might be coming in to see me for bladder leakage, or things are hanging down, some prolapse, things like that. And on discussion, there's pain. And often I'm the one who can identify just one by their history, but when I do that exam. So let's talk about some of those causes of pain that we can treat medically. So, one, there can be inflammation of the tissues. These things are often, some of those things can be reversible, right? Contact irritants. Now, unfortunately, we're on Zoom and I can't have you raise your hand, but I would lay bets that many of you use Tide detergent, always pads, fabric softeners. You wear a pad all the time, or you wear your underwear all the time. So this tissue needs to breathe. Tide is a great detergent, but terrible on the vulva. Okay. Women that are shaving different products can irritate that tissue. We want to take away these things that can cause inflammation. So detergents, the soaps that we use, love Bath and Body Works, but not for our vulva. Okay. And the other thing is vulvas don't need to be scrubbed with loofahs or washcloths. As one of my nurse practitioner friends taught me, it should just be a drive-by. Okay. And so often water is enough. It's also like a self-cleaning oven. Okay. So douching, things like that, all can irritate the tissue. Inflammation of the tissue can occur from incontinence. Leakage of urine can cause irritation and moisture. So we want to address that and protect that tissue and solve that leakage of urine. And then there are chronic things such as lichen sclerosis or lichen planus that we want to address. If your vulva, that tissue is itching all the time, that is not normal. Okay. I think I don't want to jump ahead of myself. So we'll go on. Infection. So, one of the things we want to do is we want to rule out any sexually transmitted infections. Those can cause pain, urinary frequency and urgency, discharge. So, we're always going to rule that out. All right. So, even if you come in to see me and you say, I've had the same partner, I haven't been sexually active in 3 months, a lot of times we're still just going to rule it out. As I like to tell my patients, we want to dot our I's and cross our T's and make sure that we're just not missing something that we weren't aware of. Remember, many sexually transmitted infections, you don't have symptoms of them. Okay. Oh, I love that question. I'll answer it now because it just popped up in my, well, I don't have ADD, but my, as they say, the squirrel will happen. Great detergents, anything that are not tied, sorry, fragrance free, deodorant free. So I call it the white Tide because it comes in the white bottle. It's much better. Dreft and Ivory Snow are great ones for your underwear. Avoiding fabric softeners are good too. And I think we'll talk about this more later, but I saw it pop up, so I figured I'd answer it while it's there. We want to rule out yeast, okay? Not everybody gets itching from yeast infections. Sometimes it's irritation and discomfort without discharge. So we want to rule that out. And we also want to make sure there's no bacterial infections. And that's what those swabs are for, to rule that out. So changes in estrogen. All right. This is a big factor. And we don't realize that when we're using birth control, it alters our hormonal levels during pregnancy, during menopause. But I also don't want to leave out that group of women that have been treated for cancers, such as breast cancer, and they're on things like tamoxifen and aromatase inhibitors because those medications can give you those same symptoms of menopause. So can chemotherapy. And when we talk about women that have had treatment for endometrial cancer. So realize all of these things can cause changes in estrogen, which can play a huge role on our vaginal and pelvic health. I love this picture. I don't know if you can see my pointer. If I move my pointer, can you see it? Rachel, can you see it? No.
No.
All right.
We're,
So on everybody's left is a nice, healthy vagina. The first thing I want you to look at is from the top to the bottom. It's pretty long. There's those little folds in there called rugae. That tissue is very elastic. It's nice and pink. All right. And the great thing about that vaginal healthy wall, those rugae or those little folds allow that vagina to stretch out. All right. It can lengthen. All right. Now, if we go to the right hand side, look at your poor vagina, what happens with menopause, those changes in estrogen, even sometimes in regards to women that are on birth control, some of these changes, not to this severity, but we can have some of those changes. So at that very top part of that vaginal length can be lessened because there's loss of the tissue there. The vaginal wall can become thinned. There's a reduced blood flow. That's why the tissue is not as pink and healthy looking. There's none of that rugae in there. And as a result, the tissue is not as elastic. It's not as stretchable. So there's that, as I said before, part of that length is reduced. The vulvar tissue retracts in, and so everything gets a little smaller. There's the narrowing of the opening of the vagina. It's kind of one of those things, if you don't use it, you'll lose it. So those muscles can tighten, and also the tissues can tighten. So this is called, it actually has a name for it. It's called genitourinary syndrome of menopause. And it can begin in the perimenopausal years. It can begin if you're on a medication that reduces your estrogen levels. It definitely happens after menopause and progressively gets worse as we age. So, and one of the biggest concerns is that if we don't address this issue, your symptoms may not improve. And I have a lot of people who tell me when I give them estrogen cream, it's the magic cream. It can help so many of the symptoms. It's not going to give you a great strong pelvic muscle. It's not going to fix those hip muscles, but it's definitely going to help those tissues in that vagina. Now, here's another interesting fact that you all want to know. And I know we're not talking about incontinence, but I can't not talk about this. The cells that line the vagina, these estrogen sensitive cells, also are in the urethra and the bottom of the bladder. So sometimes your urinary symptoms, urgency, frequency, sometimes even discomfort with urination, recurrent urinary tract infections, all of these changes these hormonal changes can affect that. So there's also something called painful bladder syndrome, but I realized they changed the name because it used to be called painful bladder syndrome, but the abbreviation was PBS. And probably because it was PBS and the public broadcasting system, we have now changed it to bladder pain syndrome called BPS, also known as interstitial cystitis. Oh, you know what? Hold on. I'm going to talk a little bit more about interstitial cystitis, but we'll leave the prolapse there. So, interstitial cystitis, when we talk about this painful bladder syndrome, it can be frequency, urgency, feel like you have a urinary tract infection, but you don't. You can have pain with sex, somewhat because of muscles, but also because of the pain and inflammation of the bladder lining. The reason I like to bring this up is because often this gets missed as a diagnosis, but also women with bladder pain syndrome, it can affect your pelvic muscles. Because one of the things that happens is if you always feel like you have to go to the bathroom, your pelvic muscles are tightening. All right, because that's kind of the response that happens. So, because those muscles are always tight, many women that have bladder pain syndrome have pain with intercourse, have tightening or what we call vaginismus, tightening of those muscles. I could keep talking, but I won't. And one last thing, there's something called prolapse. And I know that Rachel's going to talk about all of these things a little bit more, but it is very, very common. I had a woman come in yesterday and she really believed she was the only person that had this problem. I want to tell you there are surgeons that their primary purpose in life is primarily prolapse surgery. It is can be related to pregnancies. It can be related to the type of delivery that you had during pregnancy, but it also is there's a genetic factor there. We know that women whose mothers have had prolapse, they're more at risk for prolapse. There are lots of options for prolapse. The sooner we identify this and we can send you to Rachel and her team to work with your pelvic health, it is one way to help work those muscles. There are other devices and things that we can do for prolapse, but we want to evaluate that because if things are hanging down, that can actually cause discomfort. Even with intimacy, can cause those changes. So I'm going to let Rachel talk, and as we go through some of these disease processes again, I'll just try not to talk too much, but I'll interject us.
Right. So what is pelvic floor physical therapy? I've had a number of patients that come in and they will tell me, I don't know why I'm here. I saw my primary care. I saw my gynecologist, and now I'm here. And I'm like, awesome. Okay. So oftentimes I ask people if they had any other physical therapy. Most people have had, treatment for low back pain or an ankle sprain. So it gives them an idea of kind of what to expect. But simply because of that, we have a very similar approach. Methodology is quite the same. We're pelvic floor physical therapists. We just specialize in dysfunctions within the pelvis that pertain to your bowel, bladder, sexual health, and pain symptoms. So a number of ways that we treat those areas are listed on the screen. So behavioral is referring to things like your toileting habits. So posture and positioning on the toilet and how you breathe can play a huge role in having a successful bowel movement without pain. Looking at your water intake throughout the day, so helping to better manage urinary frequency, urgency, leakage. Sometimes a huge improvement can just be simply looking at your habits throughout the day and tweaking how you're consuming the water, what types of fluids you're consuming. We recommend, for example, to stop drinking the majority of your liquids 2 to 3 hours before you plan to be asleep. That way it matches up with normal bladder filling time, which is about 2 to 3 hours to get a full bladder. So that way you can use the bathroom right before you go to bed, and then prolonging your ability to sleep throughout the night uninterrupted by your bladder. Then we have manual interventions. So we're looking at the makeup of the muscles. So working on releasing tight muscles, improving the range of motion. So kind of a hands-on approach to addressing those types of issues. Modalities can include electrical stimulation, kinesiotape. We have a very nice biofeedback program that is can be external or internal sensors. They pick up the electrical activity of the pelvic floor muscles to give you a better awareness to what those pelvic floor muscles are doing. So it displays the electrical activity on a computer screen. So with that extra visual input, sometimes that's what kind of clicks for the patient of, oh, this is when I'm supposed to be, relaxing, or when I should be contracting. And then exercise. So pelvic floor physical therapy is much more than Kegels. However, we do need to often strengthen those muscles or go through some sort of retraining to improve the coordination sometimes of those muscles. Again, looking at the core, the hip, range of motion and strength, posture, corrections, and that sometimes gets incorporated with the traditional Kegel type exercises. But most of us here, there's 3 other pelvic floor therapists that work with me, and none of us just prescribe Kegels. So we like to look at the bigger picture again. And then education. So many people have poor awareness of their pelvis and those pelvic floor muscles, and oftentimes that first appointment is a lot of education. I really think that helps the patient have the buy-in of why they're there and why they need to do the work, what we're going to be working on, and then that reassurance of kind of the explanation of their symptoms, and then how we can improve upon it. And lastly, like the functional retraining. So I almost always look at, for example, how a person squats. A squat can give me so much information about range of motion issues, strength issues, then also how the positioning of their pelvis during that activity affects the positioning of the pelvic floor muscles and the pelvic organs. So sometimes I can improve a person's or decrease their urinary leakage just by improving in how they squat, helping them to learn how to engage their glutes. Women are extremely good at compensating and using our quads. We're naturally very quad dominant. It's why you can oftentimes see like CrossFit women with giant leg muscles and flat butts because they're using all quads and they're not engaging their glutes. The glutes are really important because they're the biggest stability muscle of the pelvis. So I often refer to them as the best friend to the pelvic floor.
So I'm going to interject, no more butt injections. We're just going to send everybody for pelvic floor physical therapy. And so not only will we fix all of these issues, but we'll all have a better butt.
You will have nice booties for the summer.
There we go.
All right. Okay. So then what to expect? So the initial visit is 60 minutes. All of our appointments are always one-on-one with a physical therapist. And we try to stick with the same provider. Now, sometimes based on your availability, our schedule availability, might need to do a handoff. But usually patients like to stick with their evaluating therapist. Just like what Kathie had mentioned, we do a thorough look at your past medical history. If you've been seen by Kathie, I can see her notes, which is also really helpful. Or any Capital Health provider, I can see the kind of what they've already done gives me insight of what to look for when I see you, and the types of questions to ask. And then I want to, hear in your own words what your history is, what your symptoms are, and then also what you want, what your goals are. I'm going to do the kind of full body assessment, posture, diaphragmatic breathing, range of motion of the back, hips, legs, and palpation of those muscles. Sometimes we can get referred pain from the pelvic floor out to those structures and vice versa. So the adductors attach at that pubic bone, which right next to the superficial pelvic floor muscles. So oftentimes if there is overactivity, kind of tightness of those adductor muscles on the inside of the legs, you can you can get overflow and tightness of those outer pelvic floor muscles. Now, most of the time, we don't have time for that internal assessment on the first visit because we are looking at a lot. In the patient education portion, kind of explain to you why I'm doing the things I'm doing, what I see, how we're going to address. So oftentimes that pelvic floor assessment gets saved for the second visit. Sometimes I will flip-flop things if I feel like that's the direction that needs to be taken. But the internal assessment for us is never required. I always let people know that I need their consent to do that. But it's important, it's that missing piece oftentimes. So if I can't do that internal assessment, it's like going for the shoulder, rehabbing your rotator cuff without the doctor or the physical therapist actually looking at how the shoulder's moving. You get a lot of information from the actual assessment.
And the other thing that's important to note, when you come in to see me, I may or may not use a speculum, but they don't use a speculum, that nice little duckbill device that every woman loves so much. They don't need to do that. And remember, it's really important to know that when we're looking, we can all look at that tissue, but we don't know what's going on with the muscles inside unless we can feel and palpate them. And as Rachel said, they're experts. This is what they do all the time. So it is important. I always encourage my patients to allow that. The only thing I always like to interject that it's very important if anybody has a history of abuse before we do these exams, that you're your own advocate and you make sure you let us know because we can slow down the process or change the pace. But it's you don't have, as Rachel said, you don't have to have it. But I just wanted to reinforce how important that aspect of this is.
Yeah, that's what I was thinking. It's like, oh, yeah, I need to mention. Part of why I mentioned that it's never required is because I don't know, there is that potential for some sort of abuse, trauma in that person's background. They're coming in, they don't know what physical therapy is, and it's kind of this, kind of takes them off guard. So that kind of stuff, it comes up in that initial appointment and we have a discussion about it. I can do things, assess externally, but again, it's just not the full picture. So the actual pelvic floor assessment it can either be done through the vaginal canal or the rectum. It starts off with an external assessment. So I'm also checking in on those external tissues, the vulva. Then I will have you do a pelvic floor contraction, bear down, cough, so I can get a general sense of what is going on in that region. A lot of people will engage their glutes, or they'll squeeze their adductor muscles, or they might even be bulging out their abdomen when they're attempting to do a contraction. So I'm getting a lot of information just from the visual assessment. If indicated, we can do sensory testing, looking at your reflexes in the lower extremity. Sensation testing can also be within the vulva, but also the abdomen, lower extremities. Then internal assessment, we are looking for differences between the three different layers of muscles. So sometimes, again, if we have that overactivity of the adductors, we might also, if you have a lot of history of leakage for a really long time and you're always squeezing your legs together and you're trying to recruit everything you have to try and prevent leaking, you may have kind of tightness in those outer pelvic floor muscles and then nothing really going on in the deeper layers. So that's some of the things that I'm looking for with that internal assessment. And we can also have differences between the left and the right sides of the pelvic bowl. Again, it could be from a hip labral tear or a knee injury that over time has affected the kinetic chain back up to that piriformis, so that obturator internus muscle, and having some sort of effect on that side of the pelvic floor. We also do assessments for prolapse, and seeing how much movement is there. And then with the muscle testing, after all that, well, then have you do some contractions. And so we're assessing the power, how strong of a contraction you can generate, how long you can hold that for. We'll have you repeat that a number of times, looking at the endurance of those muscles, and then the fast, like quick twitch muscle fibers. So how quickly can you recruit those muscles? All right, so this is a short list, actually, of conditions that physical therapists treat. Most of the conditions on the left-hand side fall under the category of pelvic pain conditions. Then we have incontinence, that can be fecal and urinary. Constipation, childbirth injuries, so that includes episiotomies, cesarean sections, and natural tearing. We know there's actually a wonderful study that came out in 2024 showing the severity of changes from comparing vaginal births to cesarean births, but then also being able to show what every physical therapist always knew, but actually now having the data to support it, of that the pelvic floor muscles and the core muscles don't return to their prior level of function on their own after having a baby. And so it just really validates what we can do, how we can support women in the postpartum period, but also the importance of being seen by a healthcare professional like us to help get you back to your prior level of function. And then we kind of already talked about prolapse a little bit. And then pre and post surgical, I have a number of patients that I've gotten recently that they're considering surgery, they're planning on surgery to fix their prolapse, but they better understand Kathie's clinic has been awesome about sending patients to us for the education piece, but also fixing the underlying mechanics that led to the development of their prolapse. So that when they have the surgery, it lasts longer, because you can actually have failure of the prolapse repair if you continue to have those poor biomechanics afterwards.
Yeah, and you do want to remember, everybody, if you have prolapse surgery, they're not doing anything to the muscles, the ligaments, the fascia, everything that supports those organs. And so that's why physical therapy is so, so important.
Yeah. And then also our prostatectomy patients, they do really well, especially if we can see them pre-surgery. And then also gender affirming surgery, so helping them navigate that change and ensuring that their surgeries heal well. We already talked about IC. I'll just quickly try to go over some of the pelvic pain conditions. So vulvodynia is referring to pain, discomfort within the vulva, so the external genitalia, often that burning sensation. As we talked about, it can affect your movement, your postures, because it's the external genitalia that's affected. Can even change your clothing choices. Sometimes women can't wear pants. They have to wear dresses all the time because of that tissue sensitivity. Coccydynia is referring to pain of the coccyx. So most of the third layer of pelvic floor muscles attach in and around the coccyx. So can have a lot of, pelvic floor influence on that bone, but also you can injure the coccyx during childbirth. So that is coccydynia is referring to any injury, pain in that area. Chronic UTIs, feel like that somewhat self-explanatory, but the repetitive infection, I would say always be sure that you're getting tested first before taking antibiotics, because it just affects the microbiome of the vulva and urethra. And then, of course, if you're always taking antibiotics, then that can disrupt a number of things from your digestive system, the flora within the bladder. So that is also a risk factor for a number of issues. Dyspareunia is referring to pain with vaginal penetration. And the vaginismus is the inability to have vaginal penetration with the consent of the woman. So oftentimes we're getting involuntary muscle spasmings that makes penetration impossible. And then prostatidynia and prostatitis are male pelvic pain conditions. Prostatitis is inflammation of the prostate gland. There are 4 different types. 2 are due to infection, and there are 2 that have an unknown cause. So again, important that you're getting tested for infection if you're taking antibiotics, or if your provider is wanting to prescribe antibiotics. And then prostatidynia is similar presentation, male pelvic pain with voiding or having to when urinating. Similar to prostatitis, but with a normal prostate exam. Okay. So ways, again, with the pelvic pain conditions, ways that physical therapists can treat these conditions. We have a number of devices that we can prescribe: dilators, the pelvic wand, perineal massage, or working to stretch, lengthen those muscles, work on any trigger points. Usually dilators are prescribed if we believe that the vaginal canal needs to be opened, whereas a pelvic wand is good for targeting like trigger points within those pelvic floor muscles. It can also be used rectally as well as vaginally. And then we have 2 different types of shapes of the dilators. So the ones that you can see on the screen are specifically for the vaginal canal. And then I'm getting my box here that we actually have dilators for the rectum. And then that last note about, I believe, speaking with the physician regarding topical treatment, oftentimes estrogen cream can alleviate a lot of this type of pain. We also have lidocaine or Valium suppositories. Okay, so this is what a rectal dilator looks like. So it's specifically designed, whereas this is a vaginal dilator. And then here's the pelvic wand. So it's uniquely designed to be used within the pelvis, different angles, because the pelvic bowl is three-dimensional. So this helps you get to different angles within the pelvis, and also getting to those deeper pelvic floor muscles that you wouldn't be able to get to manually. Right. When it comes to constipation, we are always looking at your diet, your water intake. Fiber is a big factor. The water. So, general recommendation when you don't have medical conditions where you need to restrict your fluids, think cardiac or kidney conditions, you want to drink at least half of your body weight in ounces of water daily. And majority of patients I see in the clinic are not hitting that mark. So when you're not consuming adequate water, you might be getting some water from your foods, yes, but the digestive process is going to slow down. So the food is going to sit in your intestines longer, trying to absorb more and more water. So when that happens, you're not having bowel movements as readily. So all that stuff your body's trying to get rid of is just sitting there longer, but then it's getting harder. So the stool is getting harder, which makes it more difficult to evacuate. This over time can lead to hemorrhoids, anal fissures, and actually is a risk factor for prolapse because you have to have a bowel movement, ideally every day. So you're engaging with those muscles, those organs every day. And if you're always having to push or strain, your what we were referring to as the poor mechanics that we address to help manage prolapse, but also in looking at constipation. Looking at how you breathe. So you never want to hold your breath when you're having a bowel movement. So we go over kind of the proper way to breathe so that you're minimizing that stress to have a bowel movement. Sometimes we have a lot of restrictions in the abdominal muscles. So posture plays a huge role here. So if you're always sitting slouched, then you can actually, over time, tighten the muscles in the front, and that fascia that's in between the muscles and the skin also tighten. That extends down into the pelvis, but it also restricts some of the motility, the motion within the intestines. So sometimes we will actually work on like fascial cupping is really nice to help with that. Performing a bowel massage to help manually encourage the motility of the stool. And then we'll always look at medications. So there's a ton of medications that have constipation as a side effect. So if I see that you have multiple medications that have that risk factor, probably is having an accumulative effect contributing to your symptoms. So I'll bring that up to you, encourage you to have a discussion with the prescribing provider to see if maybe there's a way to adjust that to help improve your symptoms. Oh, and lastly, the squatty potty. So I can't really demonstrate.
I should have invented it. Just saying.
No. Let me get up so I can see it. Okay. Squatty potty. As you can see the woman on here, the squatty potty is designed to sit in the front of the toilet. It helps bring your knees up above your hips. The reason that is helpful, if you look at the image on the right, when you are standing or sitting with your hips at 90 degrees, the puborectalis muscle, which is one of your deep pelvic floor muscles, lassos around the pelvic organs, and specifically here at the rectum, helping to maintain fecal continence. When you get into that deeper squat, you get the hip or the knees above your hips. It helps lengthen and relax this muscle and puts the rectum in more of a straight shot. So it makes it easier to have a bowel movement. You're ensuring that the pelvic floor muscles are not restricting that flow. So I encourage everybody, even if you don't have issues with bowel movements, to go ahead and have one because it's just good for pelvic health.
Rachel, I just wanted to let you know we're at 7:04.
Ooh, okay. I think we're okay. And then okay, so we have talked a lot about prolapse. Again, it's about breathing, pressure management, and looking at how you're managing your pressures in your day-to-day life, how you're exercising. There's so much fear around prolapse. And so I feel like it's my job to give you the confidence to keep active because no woman has died from prolapse, but women die every day from cardiovascular disease. So it is so important to stay active and stay strong. So that's how I feel that we best help with managing prolapse. Lastly, okay, when it comes to postpartum care, you can actually start working with physical therapy, ideally when you're pregnant, or even maybe before you're pregnant and preparing for pregnancy. But certainly if you're having issues during pregnancy, we can see you. We can do internal assessments. We have discussions with your referring provider. Definitely, if we see any concerns that it's not appropriate, then we will work externally and then continue that care with you as early as 2 weeks postpartum. Again, we're doing full body assessments. At that early point in the postpartum recovery, it's a lot of retraining your posture, how you're breathing. So much has changed from where the baby was that just doesn't return back to how things were pre-baby. So we kind of help accentuate your healing process and make sure that you're on the right track so that you don't start running at 8 weeks postpartum thinking you're cleared by your OB-GYN and you start leaking all over the place. So we we like to prevent those chronic conditions by enhancing your recovery process. All right. And so here is how to get in touch with us. I would like to point out that the pelvic floor physical therapy program is at the Hopewell campus. So we work a lot with Kathie's center, but we are in a different location.
We're working on that.
Yeah. Ideally, we could.
Yes, it would be great if we could do that. I'm going to go through these questions real quick that were in the post before we do any additional questions or add or comment other things. So the first question is, hi, have you heard any positive or negative results for Uyghurs let me move this, In Control supplement? So there's a lot of supplements out there. When we talk about for vaginal health, there's not been a lot of data out there in regards to using anything. However, I have a lot of women that do really well with the lactobacillus. They feel that it helps. When you talk about, if you're talking for recurring urinary tract infections, I do work a lot with women with cranberry supplements, not cranberry juice, but cranberry supplements like Theracran or Allura. And I know Allura just changed their name. Rachel, do you remember what their new name is? I think it's like Glen or something.
I'm not familiar with
It's the
one.
same company, same thing. D-Manos is also a good product. So part of it, again, let me back up. If you're having an issue, I would much rather, instead of you spending a ton of money on these over-the-counter products, to be seen and be evaluated to see exactly what's going on. Regarding detergents, yes, I often recommend anything that's free and clear. If you're really sensitive, Dreft and Ivory Snow are great for detergents. And so that is an option. But again, anything free and clear, but you really have to read the ingredients, because sometimes they say they're free and clear, but there's still a fragrance in them, or there's still another product. So be careful. Who is
If I
the
can add, sorry, real fast, one thing that you can, with looking at when you're trying detergent, is doing a wash test. So especially with high efficiency washers, there's not a lot of water that's being used. So there's a lot of detergent that gets left over, even if you are using something scent free. So simply take your underwear, get a clear glass bowl, fill it with water, put your underwear in it, and swirl it around. The swirl test. And if that water becomes cloudy, you know you have residual detergent. Certainly not wanting to use fabric softener on undergarments, but you can, with that quick test, know if you need to rewash your undergarments.
And it's even better if you do have, like, not all of them have them, but if you can do a second rinse, with just water, for and washing your undergarments separately, that is a good option. The question is, who is the professional team that works with clients with pelvic pain? So, as I said in the beginning, it could be a big group of individuals. You do want somebody that's their specialty. So again, some people will see their GYNs, and some GYNs are great, and some don't really do this area. So the Center for Incontinence and Pelvic Health, urogynecologist, pelvic floor physical therapist. Again, sometimes, like even in our office, the urogynecologist that I work with can do trigger point injections in combination with what pelvic floor physical therapy. They may get the majority of the muscle, but then there's just one muscle that just won't settle down. I mean, I just had a patient recently. It makes a huge difference. So again, it is a team approach depending on your needs. I even refer, if I can't help you, we have, in regards to those vulvar vestibular issues and you haven't improved with physical therapy, there are also, there's some in Philadelphia. There's actually a doctor near Jesse that I often refer to if there's additional issues that we can't address. So want to let you know that we do all of that initial screening. Probiotics, I do like probiotics for bowel function. I think they are very beneficial. They're showing more in the literature that they're very effective. But in regards to vaginal, there's still, it's just a bazillion of them and they're not really evaluated. So it's an individual basis, I think. Again, you want to rule out that you don't have something else going on vaginally that's causing it. And Rachel, last question is well, not the last question. Postpartum therapy covered by insurance? Yes. Sorry, go ahead.
Yes. So even though it is a specialty within physical therapy, it is, from the insurance perspective, it is just the same as orthopedic physical therapy. Same billing codes, same coverage. So yeah, I would say just check about any co-pays, that sort of thing. But what's one thing that's really nice about being in the hospital outpatient setting is that we are in network with most insurances. And then, just having a really wide outreach because of that. A lot of physical therapy practices are leaving the insurance model and going cash-based, which can be a barrier to care for a lot of people.
And in this area, I want to tell you, in both Pennsylvania and New Jersey, the majority of times you don't need to pay cash to see a pelvic floor physical therapist.
Mm-hmm. Yeah.
So please keep that in mind.
Oh, sorry.
Sorry, go ahead.
I think the next one. Yes, because we are located in the hospital, you do need a referral. However, in the state of New Jersey and actually all 50 states, we have what is called direct access. So every state's a little bit different, but you do have the ability to go directly to a physical therapist under direct access. It does depend then on your insurance if you want to use your insurance coverage. But I find it just simpler to just get that referral, it's covered, and then you get, directly, it's easier to book that way.
Right. And to be seen at the center, you don't need a referral. You can just call our office directly. And like I said in the beginning, we work very closely with pelvic floor physical therapy. Initial visit with me is an hour, again, because of all the teaching. And some of the things it's great to hear because you'll hear from me and then you'll hear from Rachel. Some of the tools I have you do, a bladder record, they like to see it. So we kind of try to get you moving in that same direction together. With us at the center, you don't need a referral, except the only exception in Pennsylvania, if you have Keystone, you would need a referral to be seen if you need referrals normally.
Did we answer Jennifer's question about, or the in control, the washing underwear separately?
No, go ahead. You can do that.
Yeah. I would say do the swirl test first. See if you have any lingering detergent. If so, then maybe doing a separate wash, a rinse, sorry, that way. But otherwise, you should be able to wash everything together, just using that detergent that we had already talked about. All right. And then, yes, if you are leaking on the way to the toilet, we can help with that. That can be a classic sign of urge urinary incontinence, and it's very well treated.
Yes, and it can also be related to your urethral sphincter not closing completely. So it looks and sounds like overactive bladder, which is frequency, urgency, leakage on the way to the bathroom. But sometimes it is actually the urethral sphincter. And that's why I always say we are the detectives to figure out the underlying cause. Let me back up. There is one in control is for incontinence. I wasn't quite sure what that question is. There are different devices out there that do biofeedback and stimulation therapy. But if you want to just clarify that, Karen, what that question actually is, there are different devices, biofeedback home devices. And so there are things you can purchase for that for biofeedback and stimulation therapy. And
I
yes,
had a question sent to me. Is it covered by traditional Medicare?
yes.
Yes.
Oh, jumped in on there. Yes, both office visits and physical therapy.
Yep.
And insurance does cover physical therapy. And like Rachel said, at Capital, we take the majority of insurances. Well, there's more. Hold on.
I keep scrolling. Okay.
Underwear, cotton. White cotton underwear is the best because there's no dyes and additives. Okay, Rachel, you go for support.
For support.
I think that's for underwear.
Yeah.
I'm not one. The only time I usually recommend that is if I don't usually. There's an occasional time, but for support, not necessarily. An interstitial cystitis, a heating pad can definitely help. There are so many things. Please, please, please. If you have interstitial cystitis or bladder pain syndrome, please do not live with that. We do in our office. I have been dealing with this issue with patients for over 20 years. The combination of what we can do and what Rachel can do is amazing. So yes, a heating pad can help, but please come see us because we can make it much better.
It talks about the supplement in control is not for UIT, it's for incontinence.
So
for UTI?
No, it's just for incontinence. I have a patient right now who's tried some herb that she thinks in combination with doing exercises and medication and things like that has helped. But I think it's one of those things, again, there's no FDA information on that. I don't know, Rachel, if you have any thoughts on something called In Control for incontinence, a supplement.
I'm going to have to look that up.
I'll do a little research too, see if I can find it. So I'll do my interjection and then Rachel can interject. So the one of the reasons that I think it's really important if you have pain with sex to have an exam, because when we talk about Kegels or pelvic muscle exercises, right, they're for strengthening your pelvic floor. And reverse Kegels are to help relax, kind of teach you how to relax. And so if you have a lot of pain and your muscles are tight, we don't want you to do pelvic muscle exercises. We call that, I often want you to work on relaxing, so that breathing. And now I'll be quiet and let Rachel talk.
Yeah, agree with Kathie. I think it's most important to have an evaluation to figure out if you need to strengthen versus lengthen, but it comes down to how you're doing it. If you're only recruiting part of your pelvic floor, it's dysfunctional. If it's not in coordination with your diaphragm, it's dysfunctional. So I find with a wide range of conditions that we can have within the pelvis, that by resetting that deep core system, that we can make a huge improvement in your symptoms just by doing that. But that is something that you have to do in person. I have to put my hands on you to give you that feedback to see how you're trying to do those activities.
Even with diaphragmatic breathing, I had a patient today that I was working with. So I probably do a little bit more than the average nurse practitioner, because I've been around before there were pelvic floor physical therapists. So I know a little bit and do some stuff, but even diaphragmatic breathing, it's very hard. And even to get instruction on how to do that can make a huge difference. And again, that's what the physical therapist can really work with. I can do that initial instruction, but they really do it much better.
Yeah. And I will say, if you try to Google diaphragmatic breathing, like the first three, I stopped going through after the third page on Google. It's not correct. It's a lot of belly breathing mechanics. So it's important to get that proper instruction. I was going to say, I wanted to answer Burger Heart. With a referral to both urogynecology and pelvic floor therapy, go with both. We
Absolutely.
can look at your symptoms in parallel, especially since we do have the fluctuation of our wait list changes. So currently I am booked into July. So certainly as soon as you can get that appointment in, you can do both at the same time.
Absolutely. And I'll say for my office, I know I'm in PA. There's another nurse practitioner that works with me. Her name is Jamie. She's in our New Jersey office. I'm only in the PA office. You can certainly, I'm also booking out a little ways, but if you call, and what can happen a lot of times is I do get cancellations, and you can ask, you just call periodically. They get to know your name, ask to talk to the Pennsylvania person, and we often can find, I do, if I get a cancellation, we'll call you. The Femi cushion underwear for prolapse support, go ahead. I haven't seen it.
I forgot about that. That's actually from one of my colleagues that put that in there. So it is it's kind of worn underneath the underwear, but it offers support for externally for prolapse. So it's not a fix per se, but it can help you manage your symptoms on a conservative approach. So yeah, the Femi cushion.
And there's actually something called a pessary, and I know that if you've ever used a diaphragm, it's similar to that, and they can be awful, but they can be wonderful. But I want to make sure women understand that it's a temporary device. The idea is, I love a pessary and pelvic floor physical therapy if that prolapse is bothering you. If prolapse isn't bothering you, if you're not aware of it, I'm not concerned about it. However, I'd much rather see you get to pelvic floor physical therapy before you are aware of it and it's bothersome. You can do a lot more with it than later.
I'm going to refer to it as the continental drift. So if you have those poor biomechanics, right now you may not have symptoms, but wait 10, 15 years and it'll drift and you will have symptoms. So better to address things early than to wait until you might have surgery.
And if I could just, from being a 60-year-old woman who's done this for a long time, I would highly recommend, if you're pregnant or you've had a baby, please go see pelvic floor physical therapy, because they will help your abdominal muscles. They will help your glutes, give you a better butt, all of those things. If you're having, if you're having any of these issues, you don't have to live with it. There are so many options. And again, it's whatever you want. Some women come in and want surgery and want to have it fixed. Absolutely fine. But even if you have prolapse or incontinence and want surgery, there's no reason not to try to work on those muscles. And so the sooner we address it, the better it off is. And here I'm going to tell you, I'm going to leave with my favorite saying, because I have to somehow, I am not on social media, but all of you, those of you who are doing your pelvic muscle exercises and doing them correctly, again, it's only a piece of the puzzle. You have to do everything else that Rachel's talking about. But every time you pee, think of me and do 5 exercises for the rest of your life after you're done passing your urine. And guess what? I tell this to my patients every single day. By the time I die, I'm hoping all of Bucks County is thinking of me doing their exercises. Okay? So that's how I'm going to end.
Did we answer pain with sitting? There was that one. Did I miss that? And then there was the referral. I have a referral to see the urogynecology office.
We did that.
Oh, yeah. Yeah. Pain is sitting kind of depends on, I mean, that is definitely something that I treat. Could be the coccydynia, could be the pudendal nerve. That's something that we didn't address, but that is the major innervation to the pelvic floor muscles. It traverses around your sit bone. So certainly, depending on where you're feeling your pain, we're kind of looking at all those structures.
And yes, for the Center for Incontinence and Pelvic Health, that's that 609, even though it is a New Jersey office, all of our scheduling, our phone appointments go through that. And if you're calling, just let them know you were at this meeting tonight. I'll see if I can try to open some. I don't have a lot of appointments, but I can try to open some hours for you. So just let them know and ask them to please reach out to me, and they can do that.
I think that is it. You got a lot of thank yous, great information, things like that. So thank you very much to our 2 wonderful speakers. We really appreciate it. Great information.